Hello and welcome to Clinical Care Options Neuroscience Podcast, innovations in early treatment of Alzheimer's disease and applications to practice. This podcast is supported by an independent educational grant from ASI. I am Marwan Sabbagh, Vice Chair and Professor of Neurology at the Barrow Neurological Institute in Phoenix, Arizona. With me today to go through some patient cases and clinical pearls regarding amyloid-targeted therapies is Richard Isaacson MD, the Director of the Institute for Neurodegenerative Diseases in Florida. Before we begin, I have a quick housekeeping note. This episode is accredited for 0.5 AMA PRA Category 1 credit, ACPE contact hours, ANCC contact hours, and AAPA contact hours. After listening to this podcast, click on the link in the show notes to take the post test and earn your CE and CME credits. All right, Dr. Isaacson, let's get started. So I have to tell you, this is a very exciting time in the era of treatment for Alzheimer's, when we now have monoclonal antibodies to kind of manage our patients in a new treatment paradigm. But before we kind of talk about the MABs, can you tell me a little bit about your perspectives on the way we should or could be approaching diagnosing patients, selecting biomarkers, things like that?
Sure. So, Marwan, great to be here, and I've really been looking forward to this because it's a treat to get to discuss cases with you and kind of go through the everyday. And what I say to just kind of summarize things is, I really believe that in the right patient, at the right dose, and for the right duration of time, anti-amyloid drugs can really make an impact. And I think how to choose these patients is tricky. Generally speaking, earlier on in the trajectory, the mild cognitive impairment phase, where people have cognitive changes that impact little bits here and there, but don't impact their daily life. They notice a word slipped, or they notice they misplace an item, but they can still work, they can still drive, they can still do all the usual things. So the degree of impact on a person's life, I think, is something that's important. And when someone progresses into for example, the moderate and severe stages of Alzheimer's disease dementia, that's not really the right place for these drugs. So earlier is certainly better. How do we choose patients? Well, we make sure that they have amyloid. That's really important. And doing a PET scan, amyloid labeled PET scan, of course, it's costly, and there's some radiation. One day, hopefully, we'll have some reimbursement options. That's been tenuous and tricky. But also spinal fluid, doing a spinal tap, looking for amyloid, as well as tau. And that's really how we make kind of the gold standard diagnosis. Where the field is going is blood-based biomarkers. We spend a lot of time with blood-based biomarkers, and I think I envision a day where blood-based biomarkers may be sufficient. It's a good assay, and if it's done in the right way, and maybe you include the amyloid and tau, put that into a formula, you're getting pretty close to being predictive that the person truly has amyloid in the brain. But we're not there yet in terms of using that alone. So, in the right patient, at the right dose, at the right duration, what else do I mean by that? I mean by genetics too. And, we're one of the lone wolves out there that have been talking about genetic testing and been pro-genetic testing for a decade or 15 years or more. And I've been getting tomatoes thrown at me. You're more senior and, more respected, Marwan. So you don't get as many tomatoes thrown at you. But genetic testing is critical. And there are people out there that say, you can't do anything about ApoE. And God, come on, ethical and insurance. And there's certain things, and you got to, do some counseling to a patient. But my patient this morning has 2 copies of the ApoE4 variant. Okay, that's important. Risk of side effects, ARIA, swelling and bleeding, little bleeds, they're real. So what I'm going to do personally is I'm going to know what I'm up against. I'm going to modify the titration. I'm going to maybe be even a little bit more cautious. How often do we do MRIs? What is the dose titration? It's a marathon, not a sprint. We're going to take longer periods of time to get to the optimal dose. And those are some general considerations. Is that kind of along what you do, or what are your thoughts?
Yeah, so many things that you covered that we're going to spend a few minutes to kind of unpacking. But absolutely, I reflect that. For the record, you and I, we can now say we told you so to the field, since we were the earliest proponents of ApoE, but we'll come back to that in a second. From my perspective, I would reflect pretty much similar thoughts and echo what you said, but I want to break it into a lot of different pieces for our discussion today. Number one is the concept of MCI and dementia. And I know, because in our clinics, we hear, oh, I don't have Alzheimer's, I have dementia. So categorical definitions versus etiological definitions, people still struggle. Professionals still struggle with this, not just the lay audience. I'm not sure we've done a good job in conveying it to the lay audience, but the lay audience and professionals need to understand a categorical definition versus an etiological definition. So when you talk about a categorical definition, can you articulate what a categorical definition of MCI is and what a categorical definition of dementia is?
Sure. So, dementia, I think, is a little bit more straightforward. And the way that I categorize that is a person that has changes in their memory or thinking skills that have really impacted their activities of daily living. They can no longer work like they used to. They need help at home, either with the finances or grocery shopping or cooking meals, preparing meals. And the phases, that's the word I use, of dementia would be the early, moderate, and severe. Those are a little bit more amorphous and a little bit tricky. And there are some definitions out there that can certainly get there. But, when someone has trouble taking care of themselves, that would be a characterized situation where you have dementia. Now, there's cognitive tests that you can fit in, like what is the mini mental status score, or what is the this score, or the MoCA, or whatever. That's one way to frame it. But I think mild cognitive impairment, the way that I define it, and this is in some ways colloquial, but also some ways as part of the definition, a person that has changes in their memory or thinking skills that are mild, they don't impact activities of daily living. And, whether you do neuropsychological testing and you find that the person's cognition is lower than expected, at least a standard deviation and a half or so below expected for age and education, whatever way you define it, I think we're trying to shoot earlier and earlier. Are those kind of the general definitions you use, or are you using something even more rigorous?
Yes. So that's exactly why I wanted to bring this up. So from my perspective, of course, it's cognitive impairment with retained independence is mild cognitive impairment. And when they go from independent to dependent in any capacity, when they lose their independence, that's when they've crossed the threshold into dementia. I consider both mild cognitive impairment and dementia to be descriptive terms, right? They are not etiological terms. They're simply you're either independent with cognitive issues or you're dependent with cognitive issues, and that's what differentiates them. And that's where people stop, because fundamentally we need to go beyond the categorical definition of MCI and dementia and go into the etiological definition. So mild cognitive impairment due to Alzheimer's, Parkinson's, Lewy body, etc. Dementia due to Alzheimer's, Parkinson's, Lewy body, etc. The reason this is important is that the categorical definitions and etiological definitions are going to matter very, very much in the era of the monoclonal antibodies. So when you go to that checklist that you started open your remarks with, that checklist implies you've already gone to the point where you consider the patient to have mild cognitive impairment due to Alzheimer's disease. So I want to say to you that I always start with a categorical definition and then an etiological definition, because I have had patients with mild cognitive impairment due to Lewy body and primary progressive aphasia. I had a patient yesterday with mild cognitive impairment due to posterior cortical atrophy. So I'll start with a categorical and etiological definition. Did you anything you would want to add to that?
Yeah, and as neurologists, we're trained to take a detailed clinical history and, progressive cognitive decline that's, more specific in the short-term memory domain, losing items, some visual spatial aspects, problem solving and planning, certainly that could be, more prototypical for Alzheimer's. But, there's other neurodegenerative dementias that don't fit and you would not want to give an anti-amyloid drug to because they don't fit with the category. And, for example, dementia with Lewy body may have dementia starting first, and then later they may have, Parkinsonism. Those patients can have premonitory signs of REM sleep behavior disorder or restless leg syndrome or constipation. Taking a detailed clinical history and also a family history, of course, doing a physical exam is absolutely critical. Doing neuropsychological testing critical, and then that's when you get to the biomarkers. And in order to use anti-amyloid drugs, we need to depend on a biomarker-driven diagnosis, as well as a clinical diagnosis that's consistent with a neurodegenerative disease, such as Alzheimer's disease.
So, that's where I think the field has changed a lot. When we start talking about selecting patients for MABs, we have gone to an evolutionary or a process where we stop. Historically, you and I know we used to do just a clinical phenotype, right? We said they had mild cognitive impairment or dementia, but we wouldn't drill down on biomarker confirmation. I think That's the one change that we're seeing, is that in order to give a patient a MAB, you have to say mild cognitive impairment or dementia due to Alzheimer's disease, and you have to prove it. And that proof comes with biomarker confirmation. And you had mentioned in your opening remarks about PET scans, CSF, and blood-based biomarkers. Can you comment about PET, and then we'll talk about CSF?
Sure. So, in clinical practice, there's, several FDA-approved amyloid tracers. I believe the first one was approved over a decade ago, back in, 2012. And there's several that are commonly used. In most areas of the country, we can get PET scans. You need a cyclotron, you need to mix the agent, you need to have access, and it has to be ordered the right way. But, doing a PET scan with an amyloid tracer, really, I think in a lot of ways, many feel is the gold standard. But I think spinal fluid, we'll talk about that in a second, I think is absolutely fine as well. It seems like in the United States, there's more PET scans that are ordered, amyloid PETs. It seems like in Europe, there's more spinal fluid tests. Aside from being more cost effective, right, and just being easier, it's an outpatient procedure, and whatever. You also get the tau. You get not just get amyloid, you get tau. You learn so much more, and whether you're going to use that information for diagnosis immediately or for disease tracking. And I'd really be interested in talking to you about how you're tracking progress on anti-amyloid drugs and progress over time, because I'm not just tracking amyloid. I'm also interested in that tau. Because the tau may be even more predictive for cognitive decline and clinical progression. In some ways, I guess I prefer spinal taps, but I'm okay with an amyloid scan. It just depends on scope of practice, like who does what type of person power you have, and where you're located. Is that about kind of how you approach it?
Yeah, I mean, to your points, PET was approved 10 years ago or more, never reimbursed, and its utility was really driven by the lack of reimbursement or the absence of use. The rumor mill tells me that CMS is gone from a hard no to a maybe, and there's might be switching their position in the coming days to weeks. So we might see increased uptake. There are a couple of comments I want to add to that. One is that PET scan reimbursement issues aside, in clinical practice has been a binary positive negative, meaning you have amyloid, you don't have amyloid. We, in research, of course, use the quantification SUVR or stenoids, but in clinical practice, it's either you have amyloid or you don't on clinical reads. So that's number one. Number two is I agree, I get more information out of CSF because I get two forms of tau and amyloid, but for a lot of people, they would prefer a PET scan, reimbursement issues aside. And then the third thing, of course, is that our colleague Gil Rabinovich led the IDEA study, which showed resoundingly that having amyloid PET changed diagnosis, clinical practice, what we discuss with our patients, how we manage our patients 62% of the time in dementia and 60% of the time in MCI. So we both agree that amyloid PET is a highly useful tool and would be great to have it in clinical practice. So let's talk a little bit about CSF. I think that, CSF, you're right. I'm doing about one PET commercially a month, getting patients paying out of pocket, but I get CSF at least 2 a week. Some of them done in my office, some of them done in interventional radiology. We, of course, have 3 different platforms that are available now. I tell you this because it depends where you are in the country, what's available to you. I think only one of them gives you 42 to 40 ratio only, and the other 2 would give you forms of tau. But I find it useful because I see amyloid goes down, tau goes up, and phosphorylated tau goes up. So it's a very, as you said, it gives you 3 proteins. And a lot of times I just send them to interventional radiology. But it's a lot of it is how you approach the patient. Patients are scared to get lumbar puncture because they read Dr. Google. But beyond Dr. Google, I tell them, we do it as a 5-minute office procedure. We use the Sprott needle and we're in and out in 5 minutes, and patients can tolerate it quite well. We're doing lumbar punctures for multiple sclerosis, for encephalitis, for meningitis. We do it for a lot of reasons, so there's no reason we couldn't add Alzheimer's diagnostics as a cause. Anything you want to add to the whole approach on CSF?
No, I think, diagnosis is obviously critical, but disease monitoring and evaluating the effectiveness of the approach, I think that's really the heart of precision medicine and precision-based care. Right. And I think a lot of people say, these meds, how do you know they're doing anything, or X, Y, or Z? Well, here we go. Let's see if the amyloid's
Right.
gone. Okay, that's good. But what is the tau doing? And I think the field isn't exactly there yet with doing this type of detailed monitoring, but it's something that we're really passionate about.
I will tell you that I'm not sure we're going to do serial CSF or serial PET in clinical practice for the MABs, but something that has not been determined yet. That's clearly, it's such a new time and era. Are you using blood-based biomarkers to treat, or would you use them as screening tools? What would you want to look at in MRI? And then we'll talk about ApoE as we get patients ready to sit in a chair.
So yes, we've been bullish on the blood-based biomarkers for a long time. We have a biorepository study, and we've been following longitudinal trajectory. So while the blood-based biomarkers, there's several commercially available assays in the United States now. I won't mention any names. There are definitely some that work better than others, and meaning like a lot better than others. So I think one has to be cautious with certain studies that are out there. You can get amyloid ratio, and you can get p-tau 181 and neurofilament light. So there's a lot of stuff out there. I'm really bullish about using these to monitor progress over time. Whether we're using anti-amyloid drugs, or whether we're using lifestyle interventions, or whether a person went on a cholesterol pill or drug or something, and we want to try to see, does that have any potential effect on amyloid and tau pathologies? We are using these blood-based biomarkers to both, in a clinical research setting, both to evaluate for risk, to stratify whether or not we should get a PET scan or a spinal fluid sample, and then potentially consider anti-amyloid drugs, but also truly we're really using it for disease monitoring, and I think that's really the holy grail here. There may even be a role to use these in side effect monitoring. Maybe there's blood-based biomarkers where, wait, someone's been an anti-amyloid drug, something's going up in the blood as the marker of inflammation, neuroinflammation or something. I think there's a lot of options, but I don't think we have sorted them out, and they're not really fully ready for prime time use yet.
From my perspective, I would tell you that I'm hot on the blood-based biomarkers for screening for the negative predictive value. If they're positive or abnormal, and I now have been doing them for a few months in my clinic, I still feel like I need secondary confirmation before I would put somebody in a chair for an infusion. So I'm not quite ready to just give infusions of MABs based on a blood-based biomarker. I think that's not settled in the field anyway. So we'll see what happens, if that'll be sufficient and that we won't need a PET or CSF. Let's talk a little bit about MRI and APOE. So MRI, of course, we always check, chronic periventricular ischemic white matter change, mild atrophy, no acute disease, like every single MRI report ever said. But I think we need to do more than that. And do you want to comment on what we would need to screen for in MRI?
Yeah, so, I think, in our patient today, as an example, it's a 50-something-year-old guy, early mild cognitive impairment, very functional, still runs a whole show that he's in charge of, very intellectually bright guy, ApoE 4/4 guy. And, with MRI, there's recommendations about how often to use MRI for everyone. Of course, before an anti-amyloid drug is given, you have to get an MRI to make sure that the person qualifies, meaning that there's not ARIA, meaning edema. You can talk about that. Too many brain bleeds. You want to make sure the person is set up for success. And then, of course, you need to do serial MRI to make sure that a person is not developing side effects of ARIA over time from use of the drug. So in a person with ApoE 4/4, for example, like this, we are cautious, and we're going to do MRI a little bit more frequently. In our practice, and this may not be common, and I'm not sure what you do, but we go slow with the dose titration. Like, Rome wasn't built in a day. I'm going to take 6, 12, 18 months sometimes to get on the maximum dose that we want to get to. And that's going to be really atypical, but that's kind of the approach we've been taking.
I do want to say to you that for MRI, I need to see how much white matter change. I need to see how many microhemorrhages. So ARIA rates are strongly dependent, not just on ApoE or genotype status, but also on their microhemorrhages. So if they have a lot of microhemorrhages before infusions, the ARIA rates are much higher. So screening 5 and below, I think we're safe. 10 and above, we're not safe. So I just want to tell you that people should be quantifying white matter change and quantifying microhemorrhages before the start of their infusions with the MABs. I want to talk about workflow in a second, but ApoE has been relevant. You said you gave your patient a homozygote in a slow dose titration way, the monoclonals. I have to tell you, I have been genotyping patients for years. I have been using it as a proxy diagnostic because we know that APOE4 carriers are very likely to have amyloid. But that's not how we're going to use APOE genotyping now. It's for risk stratification. Do you want to comment on risk stratification?
Yeah, sure. So, if you look at the various anti-amyloid studies, you can't exactly cross-compare, of course, but, certain anti-amyloid drugs have different complication rates, in terms of adverse events. So ARIA-E, edema, and ARIA-H, which is, the small microbleeds. So when you look at people with APOE4/4 or even 1/4, they have a higher likelihood of having these. They're not always symptomatic. Actually, they're often asymptomatic, but you're going to have a higher likelihood of side effects from these drugs. So in our practice, and I think what we do is we start low and go slow, and we monitor more frequently. Monitor meaning I actually call the patients for the first, this may be overkill, but even for the first couple of months, I'm going to get them on the phone and just, hey, how you feeling? Everything good? You feel okay? I'm going to talk to the spouse. I'm going to, any headaches, any confusion, any lethargy, anything. I want you to communicate with me that something's going on, and I'm going to have the caregiver and care partner and spouse or son or daughter get back to me as well. So I'm much more cautious with E4/4s. E3/4s, I especially if they have any medical conditions, I'm more cautious. But I basically kind of go with your clinical gut, and for me, we start low and go slow. With some of the anti-amyloid drugs, I've never even gotten to the maximum dose on the first anti-amyloid drug that was out. I literally 6-7 mg per kg, I'm good. Even with the current another new drug that's out, I'm still starting low, even though the study went right in with full dose. I'm starting at half or even less in an APOE4/4. And this is not exactly standard practice, but that's the way that I feel most comfortable.
So I have to tell you, I'm glad to get your perspective. I've been gun shy on homozygotes. I have to tell you, I don't have any thoughts or second thoughts about giving MABs to non-APOE4 non-carriers or heterozygotes, but the homozygotes, I've been a little gun shy. So I'm glad to hear your perspective. I might actually come back and try it at a dose titration approach and see if that works. So thank you for that tidbit. We've already talked about the fact that we're selecting patients with mild cognitive impairment or mild dementia due to Alzheimer's disease. We're selecting patients with low microhemorrhages. We've genotyped our patients. We've CSF or PET biomarker confirmed. These are all requirements for Medicare. If you go to the cms.gov website, you have to put that in. So we actually have a dot phrase in our EMR, ... lecanemab. And so we actually have a dot phrase for that in our workflow because the CMS website is asking for the use, going through a screening procedure. Are you using any kind of functional measure? So one was talked about with the FAQ. We're using an instrument called the FAST. Do you use any kind of functional measure when you're screening and identifying your patients?
So in our practice, not so much. Our patients are, I would say, on the earlier spectrum of disease, mild cognitive impairment for sure. And we basically go off of, we repeat neuropsychological testing periodically, and we kind of go by how you doing today and patient and caregiver report. But we haven't been too structured. What about you?
I have to tell you, I'm a big fan of an instrument called the FAST, Functional Assessment Staging Scale. It's a measure that I have to tell you that has a very good correlate to the ordinal progression of decline. There's so much more to talk about, Richard, and I wish we had the time. I think we could spend another half hour or hour just chatting away. I think we've done a good job in selecting and identifying patients who are appropriate. I want to say thank you very much for joining me today, Dr. Isaacson. This was a great discussion about the role of amyloid therapies in Alzheimer's disease. I want to thank our listeners for tuning in. We hope this information has been useful to your clinical practice. As a reminder, to earn credit for this podcast, click on the link in the show notes and be sure to check out CCO's website for additional educational offerings related to Alzheimer's disease, including our recently released 3-part Medical Minute video series and clinical thoughts, which provide an overview of screening and diagnosis, new treatment options that are now available, and the rationale for their use in early Alzheimer's disease. Thank you for joining us.